Hello, my name is Mark Rabat. I'm a professor of medicine and radiology and the director of cardiac imaging, as well as a program director of Advanced Cardiac Imaging Fellowship at Loyola University in Chicago, and the immediate past chair of our advocacy committee of the Society of Cardiovascular CT. Today, I would like to present three different cases on utilizing CCTA and Heartflow's AI to inform coronary artery disease diagnosis and management. This is case number 2, a 53-year-old female who presented for evaluation with a family history of coronary artery disease. She was endorsing palpitations and under a lot of stress with her 4 sons at home and at work as a teacher. She was on metoprolol. Her baseline LDL was 114, her triglycerides were 112, and her total cholesterol was 188. After discussion with the patient, we decided to proceed with a coronary CT angiogram. This is the patient's roadmap analysis, which demonstrated multivessel coronary artery disease, with the 30 to 49% diameter stenosis in the RCA and a 30 to 49% stenosis in the circumflex, and a 50 to 69% stenosis in the left anterior descending artery. This is the patient's coronary CT angiogram focusing on the left anterior descending artery. Again, you can see via the color-coded capsule the mixed calcified and non-calcified lesion in the LAD in the range of 50 to 69% diameter stenosis. Now, based off of the anatomy alone, I needed more information to determine whether these lesions were flow limiting or not. So I ordered an FFRct. This is the patient's FFRct, and indeed, all of the 3 major epicardial vessels with their respective lesions came back negative for any flow limiting stenosis. So there was no lesion-specific ischemia for the RCA lesion, circumflex lesion, nor the LAD lesion, with a lesion-specific FFRct value of 0.87 in the RCA, 0.85 in the LAD, and 0.89 in the circumflex. So with this information from the FFRct, I was able to safely defer an unnecessary invasive coronary angiogram for the patient. Now, in order to further risk stratify this patient and to assess her residual risk, I had performed an AI quantitative coronary plaque analysis. This is the patient's AI quantitative coronary plaque analysis with her patient-specific percentiles. And you can see that her total plaque volume was extensive at 928 millimeters cubed, 74% of which was non-calcified in nature. You can also appreciate that she was found to have atherosclerosis of all of the major epicardial vessels, with 8 millimeters cubed in the left main, 265 millimeters cubed in the LAD, 204 millimeters cubed in the circumflex, and 451 millimeters cubed in the RCA. Now, based off of her age and sex, you can see that she fell in the 98th percentile for her total plaque volume, total calcified plaque volumes, as well as total non-calcified plaque volumes. Now, based off of this rubric and the DECIDE registry framework, her medical management was changed to a maximum dose statin to target an LDL less than 50. We had discussed combination therapy, and at present time, she wasn't interested in combination therapy and would like to see how low her LDL would get with maximum intensity statin to start. But we'll be discussing further in clinic follow-up. I also wanted to point out that her 10-year atherosclerotic cardiovascular risk score came back at only 1.4%. So based off of her ASCVD risk score, no statin would have been recommended, despite her extensive atherosclerotic plaque burden greater than 900 millimeters cubed. And in fact, these risk calculators oftentimes fail to inform individual patient risk. Thank you for listening.